A very good afternoon to all the delegates who are here. It's really a very proud moment that POPMA, the Practicing Oral Pathologist and Microbiologist Association, is finally successful in conducting the first national conference, that too in the online mode. And we have a variety of topics starting from the lab to the translational research. So, myself, myself, Dr. Myself, Dr. Abhishek Banerjee. I'm currently the director of the lab, the practice of oral and maxillofacial pathology, Durgapur. I'm also the faculty at our Dental College Hospital. Currently pursuing my research at Department of Biotechnology, National Institute of Technology, Durgapur. Before starting on with the presentation, I totally dedicate my entire presentation and also my profession to a teacher, Dr. Kavita Chatterjee ma'am. She has inspired a lot of pathologists across the nation and also myself. I would be failing in my part if I don't mention my contribution of my guide, Professor V.V. Kamath sir, who was the ex-head of the department in the oral pathology at Dr. Shamla Reddy Dental College, and also he was the principal of that college afterwards. Dr. Lavanya Sundaram ma'am, then while the senior lecturer, a passed out graduate from Oxford Dental College, Bangalore, and Dr. Kanika Singroha, she was my immediate junior who supported me all the way in gaining knowledge, collecting biopsy samples, and now she is currently pursuing a collaborative PhD at AIIMS Jodhpur. So before dwelling onto the main topic, that is the grossing, I would like to explain the terminology, that what does it mean exactly. So it means the detailed examination and the systematic dissection of the surgical specimen in order to obtain the tissue sections. We need to get the tissue sections which facilitate the microscopic examination, and it is the first step of dissection procedure for the surgical pathology. So there is something that is what, why, how, when, and where. If we have all these five things collaborated together, then it will make a complete sense of anything. So what we need a biopsy triage, we need a grossing room, we need a grossing table, tools, and personnel, grossing personnel. May it be your lab mate, maybe your student, maybe your colleague. But yes, if you have a personnel, you can discuss and you can do a better grossing in your grossing table. So it is always wrong everywhere and for everyone if there is an insufficient evidence. So if we are doing something which lacks evidence or there is an insufficiency, we will not attend the complete thing. So as a rule, the specimen container should employ, the patient should have firmly attached label with the relevant data of patient's name, age, medical record number, time of the procedure, performance of the followed by the surgical request and the requisition form. So here we can see the two images. One is a small biopsy kept with adequate formalin, and the other is a very big specimen kept with a very less formalin. And this is something we also get in our routine practice like this. So whether we are in a position to actually do the further processing of this particular sample is what about grossing. So we need to check about the formalin quality, we need to check the form and consistency of the specimen, and then we have to go ahead. So what are the requirements for a grossing room? That is very important. We need to keep the armamentarium very much ready. That is a ruler, magnifying lens, the fixative solution, the waste bin sharps container, that is a biomedical waste management, disinfectant, weighing scale, measuring cylinder, camera for documentation, pencil and pens for labeling the cassettes, tissue cassettes, and grossing ink also. So this is something which we require, though it is many a times it is not of a much of a use. But yes, if we get some specimen like this, whether it is a hollow specimen filled with or cystic specimen, or it is a solid tumor, that depends upon many things. how much was the proteinaceous fluid which is there. So everything will covered by this weighing scale, and it need to be very much perfect, and we need to document it. So there are few other requirements in the grossing room. There is a sink with the running tap water, fume extractor, surgical blades and scalpel, grossing knife, scissor, and forceps. There are formalin absorbent pads, waterproof apron, mask, gloves, and also the grossing board. So this is a schematic diagram which is taken from a broad university, and this is the basic of what all things we require. This is also the setup, what we have already told about the grossing note, the clinical case sheet. Everything should be there, and a sink, running tap water, and a grossing table. So this is in my particular clinic where my setup where I was doing the grossing, and I was assisting one of my observer who she was learning. So this is how it looks. This is a big MRM of the breast and mastectomy. So this is not usually what we see in our clinical practice, but yes, this is a representation of what how it looks like. So this is how again it looks like in the tissue cassettes, and note that the tissue blocks are placed into the cassette properly. It should not fill the cassette, but it should just fit the cassette so that there should not be any there should not be any loose caps or the loose fit of this tissue cassettes. The orientation of the block is very much enhanced by a sponge. Securing the specimen is in the sequential position, and also there no more won't be any smashing of the specimen. This is an example on the left hand side that the tissue cassette is overloaded with a very big size of the specimen, whereas this is like the quantity is more. So we should use something which properly fits the top to the this particular horizontal slit, and it will enhance a very good processing. So this is how you can also arrange the entire thing. Avoid using letters like O, I, and all, which can create a confusion. Then if you are writing U, avoid writing V. If you are writing M, avoid writing W. So these are some letters, some trips which we can avoid to avoid confusion. So once one thing is done, probably your personnel can write that note that what does block A means, and probably you can shift the specimen. And finally, you can count all the things based on the what grossing notes you have written. So the sample orientation is a very important thing. Many a times a sample is excised, but without any orientation, it is sent to the pathologist. It creates a lot of problem if it is not in a proper anatomic position, or if the proper anatomical landmarks cannot be identified. So here we make this suture, and this is a long suture and this is a short suture. So if we write this is a long suture denotes the posterior aspect, and short suture is the superior aspect, probably we can orient it. And we can also use a disposable ruler, or we can use metallic ruler to see what is the dimension of that. This is how we can also orient the tissue, orient the sample, and we can write how many teeth are present, what all hard tissue landmarks and the soft tissue landmarks, what are the different features like the external fistula, what we can see in the squamous cell carcinoma, is the bone eroded or not. We can also take a pre-grossing radiograph, though every centers do not have that opportunity to take a radiograph of the entire sample. But yes, sometimes I do go to know that whether there is a proper bone invasion before grossing the sample or not, before destroying the sample or using up the entire sample. Specimen painting or inking is a very important aspect to know and to identify the margins of proper interest. There may be some images which I will be showing repetitive, but it creates a bit because it has particular significance at different sites. So this is how you have to take a brush and you have to ink it, and then allow it to properly. You can dry. You can use different colors for that. Indicate the specific areas of interest to the pathologist and indicate the mode of embedding. So in case of this gingival carcinoma, like this where there's a vericopapillary lesion, so there is a gingival margin, surgical margin. So you can denote the superior and the lateral borders with a different inking. Note that the inking surface of the tissue, one color will help in embedding to determine which surface is embedded down. Inking also typically reserved for excisional margin. Inking margins on the biopsy is not required since a second procedure is anticipated based on the diagnosis of the biopsy. After the formalin is properly fixed, they need to be properly, once it is done, if it is a bigger sample, it need to be properly formalin fixed. And then again, the colors of the sample, like after the dissection, primary dissection, the initial color interpretation is very important. Like white calcification denotes any osseous changes, osseous metaplasia or bone, osseous tissues, gray with fibrosis in the invasion of the lymph node, yellowish is the lipomatous fat or necrosis, red hemorrhage, blood vessel congestion, and other consistencies also which are very important for the interpretation, that is the soft necrosis, firm fibrosis, hard tissues, rubbery lymph nodes. So you have to inspect and you have to palpate the specimen also while dissecting. So this I've already told before with the following thing, and we should not, after inking, we should not cut immediately because it may spread into the neighboring structure. So though the India ink is a choice, but we can also use Fevicryl hobby colors, which is very easily available. We can dab on the extra colors with the acetic acid 5% in 3 to or 3 to 50% of white vinegar, which accelerates the drying process. Main is the thing is to for the guiding for the grossing. Next, what is the surgical margin? There's two surgical margins which are available. Do not think the free space as the surgical margin. This is of no use. We can use tumor bed margin. Sometimes the surgeons submit the tumor bed margin separately in case of tongue malignancy or in a very malignancy where any vital structures are there. So they submit a separate tumor bed margin, but overall the specimen derived margin is of greater significance based on the literature. However, if the surgeon submits the tumor margin separately, the grosser must still sample the specimen margin. So if we actually go on with the CAP protocols, that is the AJCC 8th edition College of American Pathologists, probably we cannot miss anything because everything is mentioned under captions. So even the nearest surgical margins, the distant surgical margin, positive, close, and ideal, everything is mentioned over there. And this is how we should first see the gross, and then we should go with the histopathological margin. Next is the radial margin and the shave margin. Shave margin is the greater margin area that is examined microscopically, while the radial margin allows the measurement of the exact distance between the tumor and the uh, surgical margin. Sometimes the few frozen versus permanent sampling issues also happen, but main is the histopathological after staining. So this is how the orientation, the shave and the versus the perpendicular margin is seen. This is the red lines which shows the radical sections, that is the perpendicular, and blue line is the shave margin, that is the outside margin. So this is how the inking is done. And do we see this particular box? This includes the margin as well as the tumor, and this is the tumor, the safe margin, safe distance. So this is the normal tissue. So that if we use this particular, it is the radial margin, or this is the horizontal margin which allows the examination. In case of the partial glossectomy without the portion of the mandible, these margins we have to make a note of the tip of the tongue. That is a very important, and we have to orient it based on the inferior, lateral, and the other anatomical landmarks like the floor of the mouth, gingival margin, deep tongue, and the medial and the superior margin. Depth of invasion is a very important thing, but in the gross, the depth of margin invasion cannot be seen correctly. So what we can particularly think, we can particularly see about the tumor thickness or a gross extension of the tumor. So this is how the orientation of the things can be done. We can also write in the dabbing pad, which is the what aspect. Tongue is a very important specimen that needs a good orientation. The measurement and everything need to be done. So note any negative margins is above 5 mm. So ideally the surgeon takes more than 1.2 or 1.7. When it histopathologically goes for a fixative, it shrinks. So that is there. And any kind of bone involvement or any masticatory base or the base of the skull involvement goes for the T4 aggressive lesion. Note that the tumor adjacent to the involving bone, if any part of the tumor is in the soft tissue and does not need calcification, please, there need to be isolation of one or two sections submitted as a non-decalcified tube. There are types of mandibulectomies as marginal and segmental. Marginal means there any gingival approaching lesion and not involving the bone. There is a saucerization or a pressure changes. Need to go for a marginal mandibulectomies where there is the intramedullary involvement based on the CT or X-ray. We need to go for segmental mandibulectomies. These are the different ways how we can take the sections. Next, we have to go for something for the decalcification of the hard tissues. Like what are the different things we can use for the 10% of the formic acid? We can use nitric acid in case we need to, when we have processed, but a particular area it's not getting processed, we can do a spot decalcification. And then we have to continuously monitor about what is the level of decalcification, and at every point doing a various kind of tests like blunt end pricking and all, and so that every 3 to 4 hours we have to continuously keep checking. The margins to include with the mucosal is originate is such as squamous cell carcinoma, melanoma. What we can see, we have to include the mucosal, soft tissues in the red we have shown before, and teeth need not be decalcified until and unless it is involving the tumor is involving the teeth. Yes, this is the different aspects. What we can actually do is the blue line. What we can see is the periphery outside. This is the main oral epithelium, and this is the tumor which is approaching, what is shown in the previous slides. The sections that need to be submitted at this kind of where there is a bone involvement also is the tumor, the margins, the decalcifying bone sections, skin, and the soft tissue margins. Remember, if there is a bone involvement during your, if you see the bone involvement during the time of your grossing, please do mention so that the patient can go for a adjuvant therapies like chemoradiation or radiation. This is how we can also use a manual saw, and we can do after our initial decalcification that will preserve the artifact. This is what I was talking about, that is the buccal gingival margin, lingual gingival margin. This is the inking and how we can go ahead with the sectioning of each aspect. So this is how the orientation will be done by the sutures, and this is how the radial margin, radial sections we can take for a small, for a big specimen. First we need to bisect, and this is the main bisection. Then we can go for this horizontal section and final. So it is all a very cost effective thing, so we have to do as per our expertise and needs. The essential data that need to be incorporated in the histopathology report of a squamous cell carcinoma of the oral cavity, that is the type of the surgery and the specimen that is done, the initial histopathological diagnosis, the tumor dimension and the margins, the type of the cancer, the tumor grade based on the T and M. Few things that need to be known after the grossing, that is the pattern of the invasion front. The pattern of the invasive front is nothing but it is like a bunch of the tumor which is cohesive, and it forms a kind of an island, dysplastic island. So the moment it comes out, like comes into the stroma from the epithelium, it is all together. Like there are no division yet. So it forms the first pattern or the second pattern or the third pattern. And the moment it goes for the more the advancing stages, the cohesiveness is lost. So the more the loss of cohesion, the more the aggressiveness of the tumor, and it goes as a single cell pattern or single infiltrating tumor cells. So the type 1 is a pushing border, type 2 is the finger-like growth, type 3 is the separate island, more than 15 cells per island, means a heavy island. It cannot go very far. Small tumor, less than 15 cells, means it can go little more far. And type 5 is the tumor satellites equal or greater than 1 mm away from the main tumor. That means all the single cells which are going herwards here and there. So WPOI, that is the worst pattern, the bad pattern of invasion, that is the 5, is present or not, is the main goal to see. So this is how we can see the different patterns. See, this is how the worst pattern of invasion. This is the tumor. This has gone so far from the main this thing. So this denotes the worst pattern of worst pattern of invasion, and this is like the rare dispersed satellites fulfilling the criteria like to the extratummoral lymphovascular invasion. Like the tumor cell is invading the lymphovascular invasion, so that is also LVI positive or LVI negative. So this is what I was talking about. This is the broad pushing margins, non-aggressive, pushing fingers. There's invasive islands with the cells. Invasive, this is a very aggressive font and all. Depth of invasion is again, it is very important prognostic marker, histological prognostic marker, and it determines the staging until and unless the bone is involved. So it's the vertical plumb line which is drawn from the basement membrane of the normal to the level it has invaded. So depth of invasion and tumor thickness is something different. It differs in the case of exophytic and the endophytic lesions, that we have to really look and read about that carefully. Perineural invasion is again the invasion of the tumor cells into the wrap around the perineurium, and it's without the involvement of the perineurium cannot be reported as PNI. So PNI alone is not a prognostic marker, but in combination with LVI, the lymphovascular invasion, and the depth of invasion, it considered to be a very important thing. So we can see how this is the perineum, this is the nerve bundle, and how this tumor font has already invaded into the nerve bundle. We can also see the lymphovascular invasion with the immunostains if it is we are not very convinced with that. And the presence of LVI is an indication for adjuvant radiotherapy. Lymph nodes, we have to see that we have to arrange as per the levels of the lymph nodes. Some surgeons, few surgeons, they send it separately. Few, they send it in toto. If they send in toto, we have to arrange it, and we have to know where is what, where is 1A, 1B, and where is 2A. So where is level 2, level 3, level 4, And all these things we have to know by gradually we have to read the anatomy of the lymph node arrangement, and we have to cherry pick the lymph nodes, and we have to dissect it thoroughly so that we can see the capsule, we can see the inside of the lymph node to see the metastasis, or if there is something. This is how it comes in toto with the entire specimen. And this is how the inside we can see, either we can dissect like that or dissect like this. Lymph node number is usually you should go as much as lymph nodes you can involve. It determines how thorough you are with the grossing. Something which is very important, but it is not a part of grossing, it is the presence or absence of extranodal extension. Like it goes from the inner portion of the lymph nodes to the outer, that is the extranodal or the capsular. So it determines whether it is spreading to the adjacent body cavities or not. So the take home messages is like a lot of things in the grossing. It is the very first step of the histopathology when it is concerned. Anything or any specimen needs a grossing, how it is came, how you have received, whether in a good form or a bad form, how is the fixative, how is the surgeon, how is the surgeon so concerned about the patient's healthcare. Everything you can know by how you receive the specimen and you do a good grossing. So good grossing means a good histopathologist. So my main thing is like you should keep reading to know more about this particular thing, and different grossing area, different institutions have different grossing notes, different subheadings. You should collate and you should take always the good things. And this is finally my team, like where I'm pursuing my advanced doctoral research. This works on the mitochondria at NIT Durgapur, and this is what oral pathology has to offer me. And I think it is a wonderful subject. It has no limits, and horizon is very very vast. Thank you so much, Papma, for giving the opportunity.